Good afternoon, everyone. I'm Chitapoom Choentrakool, fellow from Chulalongkorn Hospital. Today, I would like to talk about the management of recurrent patellar dislocation in children and adolescents. In our practice, we have found many cases of recurrent patellar dislocation in children. Today, after discussing this topic, we will focus on identifying the most effective management strategy for our children. Acute patellar dislocation is the most common acute knee injury in children. The incidence of acute patellar dislocation is 43 per 100,000 children, with a recurrence rate of more than 60%. It is more common in girls than boys, and the dislocation almost always occurs to the lateral side of the femoral trachea. Next, I will talk about the following outline. There are many classifications, but one of the most used is this classification in the picture. They divide children into 5 groups. The most severe type is at the top and the mildest type is at the bottom. First is the congenital dislocation. Second is the permanent dislocation. Third is the habitual dislocation in flexion. Fourth is the habitual dislocation in extension. And the last one is the most common type is the episodic dislocation. About the risk factor, there are 3 main risk factors for recurrent dislocation. First is soft tissue, second is the bony wrist stain, and the third one is the fracture that affect the Q ankle. What is different from adult? In this section, I will discuss the important factors that may differ from or be similar to those in adult. MPFL, or medial patellofemoral ligament. The starting point for the femoral tunnel position is called the shorter point. We can use this point just like in adult to place the femoral tunnel for MPFL reconstruction. The point is located distal to the distal medial femoral fascia with mean minimum distance of 9.9 mm. The term of generalized hyperlaxity can assessing using the Brighton score just like in adult. However, the cutoff is different from adult. The cutoff in adult is more than or equal to 4, but in children is more than or equal to 6. If the children have generalized hyperlaxity, we need to work up for cardiac, skeletal, or ocular abnormality to identifying any associated syndromes. About the trachea dysplasia, we can use the dual classification in the same way as in adult. About the growth of the trachea dysplasia during adolescence, there is no significant change in the sulcus ankle after 11 years old, meaning the morphology of the trachea remains the same. And they suggest early surgical correction of the trachea to help ensure the normal development of both the trachea and patella. About the patella alta, we can use the Cardiac index for measurement, the research to measurement, and the research from France include 300 healthy children and found that the Cardiac index had excellent reliability with normal value decreased with age. The Cardiac index was consistent starting at 12 years old. The research on patella alta in children with patellar dislocation involved MRI scan of 140 knees. The study found that the Cardiac index does not change with age in children with patellar dislocation, meaning in patellar dislocation, development does not improve patella alta. Valgus knee. Normal alignment in valgus knee change with age. At 3 or 4 years old, it can be up to 15 or 20 degrees of valgus. And by 12 years old, it typically corrects to 5 or 7 degrees. Normally, femoral anteversion decreases with age. It is 40 degrees at birth and 15 degrees at maturity. To assess femoral anteversion, we use hip internal rotation during physical examination or a CT scan, which is the gold standard. The lateral tibial tubercle is measurement using the TTTT distance, which increases with age. In adult, the distance cut off is greater than 20 mm. In children, the normal distance is 8.5 mm, while in the children with patellar instability, it is 12.1 mm. Next is the management in children and adolescents. According to the classification I mentioned before, The more severe type are prone to surgery, while for the most common type, episodic dislocation, treatment can be either surgical or conservative treatment. That depends on many factors will discuss later. For the first-time dislocation, a systematic review of 20 articles on a first-time dislocation in a skeletal immature patient found that the outcome of conservative treatment are similar to those of the surgical treatment. And the conservative treatment can involve cast or spin immobilization for 3 or 6 weeks with weight bearing as tolerance. Additionally, what's that middle rate of wrist strengthening and pain control are important components of treatment. Next, we have the predictive factor for recurrent patellar dislocation after a first-time dislocation in children that can help determine a conservative or surgical treatment which is appropriate. In this study, found that the 4 factors, that is trochlear dysplasia, history of contralateral dislocation, skeletal immaturity, and Carton-Lersham index more than 1.4. If all 4 risk factors are present, the recurrence rate is very high, up to 88.4%, and they suggest that the surgical treatment may be considered. And we have the patellar instability score. The factor in this score is age, bilateral instability, trochlear dysplasia, patellar height, TTTG distance, and patellar tilt. If the score is more than or equal to 4, the risk factor of recurrent dislocation is 5 times higher, and surgical treatment may be considered. About the operative treatment, the main indication is recurrent dislocation, osteochondral fracture more than 5 square millimeters or located in the weight-bearing zone. The concept of the treatment for the recurrent patellar instability is a la carte technique. That means we have to find the abnormality and fix that abnormality that we have. First, I will talk about MPFL reconstruction. I will discuss in the 3 main components: femoral fixation, patellar fixation, and graft selection. The femoral fixation. We can use the shuttle point as I mentioned before. The point is located distal to the distal medial femoral facet. The drilling angle is 15 or 20 degrees distally and anteriorly in both the coronal and sagittal plane, and can be guided by intraoperative fluoroscopy. A systematic review and meta-analysis of femoral fixation methods found no difference among the soft tissue pulley, interference screw fixation, or suture anchor fixation in terms of recurrent instability or complication rate. Next is the patellar fixation. In 2015, biomechanical study on patellar fixation in MPFL reconstruction found that interference screw fixation is significantly stronger than suture anchor fixation. And in 2022, the paper found that the interference screw was significantly stronger in terms of stiffness compared to the suture anchor tool. About the graft selection, we have the meta-analysis of recurrent instability rate and patient reports outcome among autograft, allograft, and synthetic graft, and found no difference among us. In autograft study, comparisons were made among cartilage, quadriceps, and semitendinosus tendon, and no difference was found in recurrent instability or complication rate. And the research by Dr. Bakasit, Dr. Posawat, Dr. Adinan, and Dr. Bancha compared superficial quadriceps and hamstring autograft, found no significant difference between the 2 techniques. Both show no post-operative complication or recurrent dislocation in medium to long-term follow-up. Regarding the augmentation technique, using polyester suture augmentation with the semitendinosus tendon result in better outcome compared to using the tendon alone. About the lateral patellar retinacular release, that is not isolated procedure. The indication for it is a patellar tilt more than 20 degrees. The procedure can be performed by lengthening at both the superficial and deep fiber layer. After lengthening between 1 or 3 cm, the layers are sutured together. Distal stabilization, the classic mobilization of the tibial tuberosity seen in adults, cannot be performed until skeletal maturation due to the risk of apophyseal injury. However, during skeletal immaturation, soft tissue procedure can be performed. The first procedure is the Gammon procedure, where the posterior portion of the patellar tendon is peeled off, and the patellar tendon and periosteum are medialized. And the second procedure that called the Recurrent procedure, which involves the medial transfer of lateral thirds or half of the patellar tendon. Tracheoplasty. The group-depending tracheoplasty by Dujour can only be performed after skeletal maturity is complete. The best indicated for trachea type B and D. During skeletal immaturity, tracheoplasty can be performed with erosion of the epiphyses. The indication for this procedure is in the children with permanent or habitual dislocation, with a flat trachea and no supratracheal spur. The procedure was done by epiphyseal osteotomy. Is performed is done just 5 meters behind the joint surface to be lifted, followed by impacting a bone graft into the osteotomy site. About the guide growth, the indication is genovacus more than 20 degrees with more than 12 months of growth remaining. This procedure can collect the mechanical exit to the center of the knee and is performed at the medial distal femoral epiphysis to stop the growth on the medial side. Femoral derotation osteotomy is indicated for femoral anterotation more than 20 degrees, hip internal rotation more than 85 degrees, external rotation less than 10 degrees, or pelvic femoral angle more than 50 degrees. The osteotomy can be performed at the intertrochanteric, diaphyseal, and supracondylar site. Post-operative management that depends on the procedure performed and its lack of the agreement on a specific approach. The time to return to sport length from 3 or 8 months. From the ISOCOS Sport Medicine Committee has proposed criteria for a safe return to sport after patellofemoral instability, which include complete bone healing, no knee pain, full range of motion, no effusion, complete tending, limb symmetry index more than 85%, and psychological ready to return to sport. Summary of my topic. For a first-time dislocation, conservative treatment is usually recommended. You can also calculate the patellar instability score, and if the score is more than 4, then surgical treatment may be considered. For recurrent dislocation or osteochondral fracture greater than 5 square millimeter or located in the weight-bearing zone, operative treatment is indicated. About the operative treatment, first we need to identify the problem, whether it's related to the soft tissue, bone, or the Q ankle. Then the procedure is selected based on the specific problem that we have identified. And this outline is the indication for each specific procedure. Thank you for your attention, and I would like to thank all of my professors at Chulalongkorn Hospital for helping me.
So, thank you.